All right, for this week's Interviews with Experts, I'm here with my good friend, Dr. Stephen Gillaspy, via Skype. Dr. Gillaspy is Associate Professor in the Department of Pediatrics at the University of Oklahoma Health Sciences Center, and he is a pediatric psychologist. So, Stephen, if you wouldn't mind, maybe first tell us a little bit about who you are and what you do.
Sure. Like you said, I'm a pediatric psychologist at the Health Science Center. I've been here since 2006 after I finished my fellowship. My fellowship was in primary care and health psychology. After I completed the fellowship here at the Health Science Center, then I started my faculty position in the Department of Pediatrics.
Okay. And can you tell us a little bit about what a pediatric psychologist does in the Department of Pediatrics?
Sure. Well, I think the way I would describe a pediatric psychologist is kind of compared to the adult realm where you have health psychology. I think pediatric psychology is health psychology with kids. So I think that's one way to think of it as a way to distinguish it from traditional kind of child clinical. So traditional child clinical is really focused more on routine mental health, more traditional outpatient. Pediatric psychology is really working with some of those same problems, but working in a medical setting. So whether it be in primary care settings, whether it be on inpatient units, but working with kids that are usually presenting for medical issues rather than mental health issues.
Now, I know in your job you do both clinical work every week, sometimes every day, and you do research all the time. In your clinical work, what kinds of things do you do, or what's your specialty?
Sure. So right now, my clinical work, I used to do inpatient work. We had an inpatient liaison service where we would see kids that were hospitalized for medical reasons, but they had psychosocial issues. I used to do that. Now, primarily, the main focus of my clinical work is with a multidisciplinary pediatric obesity clinic. So we have a specialty clinic that has 4 disciplines in it. We have a pediatrician with expertise in pediatric obesity. We have psychology. We have a dietitian and a physical therapist. And so it's a comprehensive clinic. And so right now, that's the main focus of my clinical work.
I know in a lot of what you do, it's very multidisciplinary. So you're interacting every day with doctors, nurses, nutritionists, all those kind of folks, and that might be surprising to the students.
Yeah, in fact, I would say we just recently have gone through where we're interviewing folks for fellowship, for postdocs and internship. And we have our applicants, usually they interview with psychologists, but they also interview with medical staff. Because for the type of work we do, they spend as much or more time collaborating with medical professionals as they do with mental health professionals. All of our clinics are multidisciplinary, whether it be our pain management clinic, our weight management, sickle cell, primary care, inpatient. Most of your interactions are going to be with other medical professionals.
It must be a real challenge to fit the couch into those exam rooms, and yeah, no couch involved.
Well, and the other thing related to that is we really go to the patient. So in traditional kind of child clinical, it's a routine outpatient setting. It's more the 50-minute sessions. The kind of work we do, we're embedded within medical clinics. So we see patients and families in exam rooms, on inpatient wards, if they're down getting physical therapy, if they're on the dialysis unit. We really go where the patient is versus traditionally where they're coming to see us.
I know we certainly talk a lot about obesity in this course, with sort of a bird's eye view. Can you tell us something from kind of the front lines? Is obesity a big problem in Oklahoma? And what are you seeing in the clinical world as far as obesity among kiddos?
Sure. So I would say it definitely is a problem across the nation as well as in Oklahoma. I think one of the things that's different doing obesity work with kids versus with adults. The focus is always about weight reduction because that's the only way to reduce an adult's BMI because adults aren't going to grow any taller. So the only way to get BMI is really a marker for health risk. And so for adults, the focus is always on weight. With kids, BMI, we have to plot their BMI on a growth curve. And so BMI is not only is it dependent on height and weight, but also on their gender and on their age. And so for kids, they're going to continue to grow. And so the focus for our clinic is not necessarily about weight reduction. A lot of times our goal is to slow down the weight velocity or the BMI velocity. So we have to do a lot of education with both our patients and our parents about our goal is really about health, and it's not necessarily about weight. Sometimes weight will reduce, but even if our kids just kind of stay stagnant, so they quit, so their weight remains constant, a 6-year-old is going to continue to grow, and in a sense, they have the potential to kind of grow out of that. So I think that's one of the fundamental differences between kind of adult and kid, and that's hard for parents to grasp. It's hard for patients. Patients want to see weight loss, and we don't always preach that. And so I think that has a big influence on how physicians and other people who try to intervene, because they think if they have a conversation, they counsel someone, they come back in a couple months, if they haven't lost weight, then they failed. And really the goal shouldn't be weight loss in a lot of those cases. So I think that's a huge implication, because that affects how people deal with obesity from a public health perspective, from a primary care perspective. So I think there's lots of education that needs to be done.
And part of what you said there is about providers' conversations. I know some of the work you do, because I'm involved in it, is working with training future providers, medical residents, how to have interactions with patients, or in a pediatric setting with the patient's parents about health issues. Can you say just a little bit about that?
Sure. So, like you said, we've done a lot of work in training providers how to do brief interventions, based off motivational interviewing. But I will tell you that is when I go out and we do lots of talks, the pediatrician that does the weight management clinic with me, we do lots of talks for different organizations, whether it be the Oklahoma State Medical Association or other provider groups. And people are really leery about how to have that conversation. They're reluctant. And I always kind of use the example. I think obesity is where tobacco was 25 years ago. Providers thought if I talk about smoking with my patients, they'll be irritated. They won't understand why I'm bringing it up, and so they're reluctant to have that conversation. I think to a large degree, providers have gotten over that with tobacco, but I think we're still at the same place with obesity. They don't feel like they have the necessarily kind of skills or tools to have that conversation. The other thing is, if they think that the goal should be weight loss, they don't feel like they have the tools because they can't necessarily prescribe something for them. So related to that, Dr. Whedon and I, who work on all the pediatric obesity, we have a contract with the state health department and the Oklahoma State Medical Association, where we're doing monthly CMEs, free CMEs for physicians to focus on weight management. And a lot of that is how to have that conversation, what to screen for, really how to impact obesity, pediatric obesity at the primary care level.
Great. Well, in closing, could you tell us just a little bit about how you came to get this very interesting career? When you're speaking to a group of students in undergraduate course right now, if you could go back to there, how'd you find your way to this career?
Sure. So I was a psychology major in college. At the end of my psychology career as an undergraduate, I knew I wanted to do something in psychology, but I didn't know if I wanted to do clinical psychology. I liked all the animal behavior stuff, and so I didn't know if I wanted to be experimental. And so I took some time off. I got some work experience. So I worked on an inpatient adolescent psych unit to get some clinical experience. I worked with a multidisciplinary research group for 3 years. And so I got both research experience, I got clinical experience. And so through that, I realized I wanted to be a clinical psychologist. So that was kind of the first step. Once I got to graduate school, I had interest in working with kids. I also had interest in health psychology. And we had 2 tracks in our program. So I did both of those tracks. And so I think that kind of gave me the skill set, both the health psychology skill set as well as the child skill set. I've always had interest in kind of both, with adult health psychology as well as kids. So that's kind of the path that took me to my position now.
Gotcha. Well, I think this has been very interesting, and appreciate your time. Thanks, Stephen.
Hey, thank you.